I'm Linda Gore Martin, Professor of Social and Administrative Pharmacy at the University of Wyoming, recently retired. I have no conflicts of interest in the content of this presentation. The workbook that you have has multiple objectives, and I've condensed those down to 4 objectives for this presentation. Please use your workbook for more details. We're going to provide a context of importance to you, the learner, appraise the concepts of outcomes and costs, design basic pharmacoeconomic analyses, and select or interpret appropriate patient-reported outcomes instruments. So what is the problem not being addressed by traditional studies? What we're talking about here are clinical studies. And there's a large public health issues in the real world that aren't being addressed by these studies. And the real world has limited resources, especially money, but also time and personnel. And just as an example, in 2014, the gross domestic product of the United States was somewhat over $17 trillion. Of that, $3 trillion was spent for health expenditures, or about 17.5% of the gross domestic product. And prescription drugs were $298 billion, or about 10% of the healthcare expenditures. This means that every man, woman, and child in the United States spent about $9,500 on healthcare expenditures. Many people believe this is too much of our gross domestic product, and it is by far the most of any country in the world. And just for an example that we're using in this presentation, in diabetes, as you can see, there are a lot of people that have diabetes, about 8.3% of the population. Many of those are undiagnosed, and therefore their complications are more likely. There's about 2 million being newly diagnosed, and it's the 7th leading cause of death. So in our patient case, part 1, you're asked to state an economic problem based on the information on the previous slide on diabetes. So what is true about diabetes? What kind of economic aspects? Do they utilize more resources? Does their utilization increase over time? Do more patients develop diabetes each year, increasing the need for resources, or all of the above? And all of the above are correct. There are, of course, many more economic issues related to diabetes. Why do you care? It affects your practice, your patients, your decisions, your institution. It affects you personally. Your insurance premiums are directly related. It affects the economy of the United States. On the other side, it identifies areas where you or your residents and students can do small studies or even participate in large studies. Health outcomes research measures the effects of changes in outcomes. It always compares alternatives so you can use it to make decisions. Which is better? You can use multiple alternatives or just compare the new alternative that you're looking at, the new treatment, to the alternative best treatment, the standard of care, or no treatment. No treatment is very different than placebo, which is an alternative treatment. It just has no activity. Why you want to do this is because you want some real-world information. We call this effectiveness. Controlled studies are efficacy, and it's really an artificial world. We are seeing more and more studies that are piggybacked onto controlled clinical trials. because of the convenience of being able to get the economic information, but they are still artificial and not real world. It does provide a measure of value. Pharmacoeconomics is a subcategory that you must have one of the alternatives being related to pharmaceutical products, services, or programs. And all of this is related to value. Value-based purchasing is the new normal in the healthcare world. And this is health outcomes per dollar spent. A patient health outcome is the clinical outcome, the quality of the outcome, plus the satisfaction. And we'll be talking about this more when we talk about patient-reported outcomes, or PROs, because those are an important component. So we just reviewed the problem of health expenditures, that outcomes research and pharmacoeconomics are decision tools. That's the value of the studies. And they use value as the ultimate endpoint. So now we need to know what outcomes and costs are. So value is the outcomes per dollar spent, and costs are the dollar spent. So outcomes are the ultimate result of an intervention. We also call these consequences or benefits. The endpoint is how the outcome is measured. We have actual outcomes that you can directly measure, such as death and myocardial infarction. And we have surrogates, because the actual outcome may take a very long time to and your study is a much shorter time, so we often use a surrogate endpoint. We can use an intermediary, which is something that occurs during the progression of a disease, such as narrowing of the lumen, being a surrogate for myocardial infarction. Or we can use something that's not intermediary, but is associated with the final outcome, such as laboratory values, hemoglobin A1C, and diabetes, for example. Patient-reported outcomes may be actual or surrogates. Cosma in 1993 had a model that was developed called the ECHO model. And what this stands for is economic, clinical, and humanistic outcomes. And she put them into categories that are overlapping. For example, pain can be either a clinical outcome or a humanistic outcome. So let's look at our patient case again. So diabetes has many outcomes, and the case asks you to identify as many outcomes as possible for each type, and while trying to identify an actual and a surrogate for each. Remember, outcomes are always directional. They're usually stated in the desired direction. Decreased myocardial infarction, decreased hospital days, increased quality of life. So because you were asked to list, in this case, all answers are correct. So decreased A1C is a surrogate for diabetes. Increased ability to care for self is a actual humanistic. And there are many interrelated, such as decreased pain. So now that we have outcomes identified, we need to talk about costs. There are multiple types of costs, and it depends on the perspective. Costs are always an indicator of opportunity cost. Opportunity cost is the use of a dollar for its next best use. If you spend a dollar for something, you can't spend it for something else. Some of our fullest economic assessments may include lost opportunities. If you're trying to decide if you want to do a PGY2 residency, you need to consider the opportunity cost of the lost salary. And this, of course, depends on the perspective. Costs and use of resources follow the PARETO principle. This is very, very important when you're trying to utilize your time and personnel resources to the best abilities. And that principle says that 20% of the subjects will use 80% of the resources. And healthcare expenditures follow that very well. So there are three types of costs. Direct costs. And direct costs have two subcategories. The first is direct medical costs. These are the costs that are included in the gross domestic product as medical expenditures. They may be fixed, meaning that the cost is there regardless of whether there are patients or not, or variable. In most cases, you're only interested in the variable costs unless you're going to need to expand in facilities or other areas of fixed cost. Direct non-medical costs are costs that are incurred related to a disease or disorder but are not direct medical costs. This includes travel to medical visits, special diets, not including prescription diets, which are healthcare costs. Indirect costs are only related to productivity. There are two types of indirect costs. There is absenteeism, where the person is not present at work, and there's presenteeism, where they're present but they're not producing at the appropriate level. And finally, intangible costs. This is costs of pain and suffering, and cost of limits on functioning. These are very hard to value, so even though they're very important, they're often not included in economic assessments. We've been talking about perspectives. There are 4 perspectives in economic assessments. One is, the largest is society. And society includes all of the other perspectives, so it gets quite complicated. Government may be a surrogate for society. If they are serving as the insurance company, such as Medicare, Medicaid, and the Department of Defense, then they become a payer. A payer is the group that is actually paying for the services. The insurance companies, employers, if they're self-pay, self-insured. Another group is the provider group. This is the healthcare institutions that are providing the services. And finally, there is the perspective from the patient. The patient's costs are only their out-of-pocket costs, and this includes co-pays, co-insurance, and deductibles in addition to any out-of-pocket costs. All of their direct non-medical costs would be out-of-pocket. So in the case part 3, we look at the cost by perspective. And the costs for the diabetes that we presented earlier are from the society level. And each of the perspectives is interested in different costs. So society is interested in all of the costs, even though they may not report the intangible costs at some point, as is the patient. The payer is interested in direct medical costs because that's what they're paying, and indirect costs because most of their customers are employers and they're interested in the productivity. The provider is only interested in direct medical costs, possibly in the intangible of satisfaction. Published studies, especially from the provider perspective, may be directly adaptable to your institution just by plugging in your costs into their transparent program. However, if it is a foreign study, the differences in healthcare systems may not allow you to do this. So is it a cost or a benefit? It's difficult to determine at times. And in some cases, like in cost-benefit, it doesn't really matter if you put it in the wrong category because they are both in dollar amounts and they will come out in the final analysis. How are you measuring your costs? Are you micro-costing, which is identifying the cost for each individual item? For example, in the pharmacy, you would have salaries for the pharmacists, for the technicians. You would have the cost of the drug, the cost of the IV bags and IV materials, and you would just add those up. Or you may use an aggregate cost, and this is frequently used. An ICU hour, where they have determined through some studies on microcosting how much an average ICU hour costs, and then they would use that as a cost. Many institutions use a cost-to-charge ratio after they've determined the initial cost, and this takes an aggregated cost, say for an ICU hour, and determines the cost and then their markup, and they use that ratio. So anytime you see an ICU hour, it is a percentage of the charge that they use for that. Charge and costs are very different. The charge for one perspective becomes the cost for the next. So the supplier's charge to the institution, to the provider, becomes their cost. Indirect costs are determined by various methods. If you have a small group, you can actually use actual costs. But in most cases, you need to use a human capital approach, which is using databases of wages by sex and age and occupation. What this does is totally undervalues people not in the workforce. And at times we use a proxy to value them, and that proxy may be the cost to replace a volunteer if you had to hire them, or a homemaker. We also use willingness to pay, which is a bidding process. How much are you willing to pay for a person to do this job? And we also use the willingness to pay concept for intangible costs. So we described outcomes and costs, and we measured costs in the last piece. Now we'll go on to the economic evaluations. So pharmacoeconomic evaluation is the evaluation of cost per outcome of alternatives that include at least one related to pharmacy. So you may have pharmacy, a new drug therapy being compared to psychotherapy. Assumptions are usually included. These are often in probabilities or averages, so those average costs, the cost-to-charge ratio, or in the probability that over a certain amount of time you will be having a myocardial infarction. This is very similar to the probabilities that you're using for number needed to treat. You may use actual patient data. That may be your patients in your institution, or it may be patient data from large databases such as insurance companies, or you may actually be using modeling where no real people are involved. They are a hypothetical group of healthy people that go through the model. We're going to talk first about a couple of types of modeling. So the first is the decision tree. The decision tree starts with the decision node, which is the only place that you have any input or control into the system. And you do your alternatives. Your standard of care, your best alternative is usually at the bottom, and the alternative that you are currently looking at, the new possibility, is at the top. You may have more than two alternatives in a decision tree, and all of the branches look identical for all of these. A chance node is the probability that an outcome will occur, either a effectiveness or a adverse effect, or will not occur. And the total of the outcomes, probabilities of the outcomes, has to equal 1. And just as an aside, this looks very similar to later in the chapter, the standard gamble, where your alternative of staying in the state forever is the bottom, and your new alternative of dying immediately or the utility is the chance node. And the answer, the utility, is always the top number, this P1. MARKOV model, the decision tree is linear and not as realistic as the MARKOV model. The MARKOV model includes the concept of time and disease states within that time period. And rather than being linear and just going one direction, you can stay in the state, you can move forward, and in some cases you can go back into a previous state. All of these aspects need to, their probabilities need to add to 1, just as they do in the decision tree. Because you're using assumptions, you need to do sensitivity analysis. This is to determine the effect of the assumptions. If you change the probability of something happening or the cost, what does that do to your final decision? And it identifies the most important assumptions so that you can simplify your study. And we use various techniques for this. We use the one-way sensitivity analysis, where you're just changing one aspect at a time. We use the scenario analysis, where you create scenarios. Analysis of the extremes, where you're using the confidence intervals to create the changes in the ends of the confidence interval to create the changes. And what you're looking for is that when you make changes, that in the end your decision does not change. We call this being robust. If it does change, you may need to look at that particular assumption and determine if that's really a reasonable assumption before you continue on in your study. Another piece that you have to do in economic analyses is discounting. This must be done if costs or outcomes occur over more than 1 year. And you do this because money and outcomes are worth more now than in the future. And you do it using a discount factor, which converts future amounts, either costs or outcomes, to the present value. The rate is arbitrary. You may use a government rate, you may use the literature. It's not really an inflation rate. There's some other aspects, but it is the what is considered the amount of the cost of the opportunity cost. You often use a range of discounting factors, which is a sensitivity analysis for this. And you sum the discount factors over the years. So you do, for your first year, you do this, and then you do it for the second year, and then you add them together until you have all of your years together to get your final amount. So when you're looking at a major pharmacoeconomic problem, you want to determine the least costly alternative. And this isn't just the least costly for the drug component. It is the cost of the whole health event. So you need to include all the costs that are involved, and you want the least costly alternative, which may be a more expensive drug as we go through this. So first you need to know if outcomes are being measured. If they're not being measured, you really just have a cost analysis or a cost of illness study. And these are described in detail in your workbook. If the outcomes are being measured, are the outcomes equivalent? And this is both the effectiveness outcome and the adverse effects outcomes, and they are within a clinically significant range. If yes, you can do the rarely used cost minimization, because this doesn't happen very often. If not, then you need to do a full analysis. And there are three full analyses: cost-benefit analysis, cost-effectiveness, and cost-utility. And this is comparison of the four methods that we're talking about. You have a great detail on each of these in your workbook, and you can walk through them. But basically, the costs and the outcomes and whether you can compare different outcomes determines which analysis you would want to use. So cost-benefit, the costs are in dollars. If you're in a foreign country, they would be in their currency, but we're talking about dollars in this case. And the outcomes are also valued in dollars. So it's the cost of a myocardial infarction. So it's the costs that you put in and the costs that you save, the avoidance of, say, a myocardial infarction. The advantage is you can compare different outcomes. You can compare an immunization program to a smoking cessation program. The threshold value is 0. So you would accept any new program that has a cost savings of 1 cent or more. Cost effectiveness, your costs are in dollars, your outcomes are in natural units. And these are those echo outcomes of a myocardial infarction prevented, a cure, a hospital day saved. You cannot compare different outcomes since your natural units have to be the same. And the threshold value is as determined. In the larger cost effectiveness models, this is normally $50,000. We are seeing more in the $100,000 range, but it's always more than 0. Cost utility, which is a subgroup of cost effectiveness, uses dollars, but they have converted the natural units into quality adjusted life years so that you can compare different outcomes because they have been converted into these qualities. The threshold value is as determined, and it's always greater than 0, very similar to the cost effectiveness. And cost minimization is the costs are in dollars, the outcomes are not relevant since they're the same. You cannot compare different outcomes because of that. And your threshold value is 0. You would use the least expensive. So when we're talking about those threshold costs that are greater than 0, we look at the cost effectiveness plane. And what this does is helps you determine whether or not you need to do a study. So if you have increased cost and decreased effectiveness of your new, and you're always comparing the new alternative here, of the new alternative, this is considered dominated and you would never go with this decision. On the other side, if you have a decreased cost with increased effectiveness, this dominates and you would always make this decision. The areas where you need to do studies are in these quadrants where you have an increased cost but you have increased effectiveness, or you have a decreased cost and decreased effectiveness, but the difference in effectiveness isn't worth the extra cost. For a $50,000 threshold, all of the areas in the gray would be considered and that would make your decision. As you increase that threshold to $75,000, this area where the increased cost and increased effectiveness becomes larger, and this area where you're not going to go with the where you're going to go with a less effective area decreases. You're not going to have as many decisions in that part where you're not going to go to an increased effectiveness. All of these threshold values are incremental costs. And what an incremental cost is the cost of one additional effectiveness unit, either the natural unit or the QALY. And you use the incremental cost effectiveness ratio, or ICER, and this is, the formulas for these are in your workbook. So what is a QALY? A QALY is a quality adjusted life year. It creates a common unit for comparisons of interventions while incorporating some humanistic outcomes into the cost effectiveness assessment. It's composed of two independent factors, time and quality, time in years, which is a problem for acute and very short-term situations in that often your QALYs become very, very small and your costs, your incremental costs, therefore, are very large. And quality as a utility. And to get a QALY, you sum the time and qualities, and these are in your the health states, similar to a MARKOV model where you have multiple states and you have to sum those together, and then you subtract the new alternative from the old alternative from the new alternative to see if it's a positive number. Utilities are a very complicated concept, and they're obtained from various sources. The standard is the standard gamble, which is that decision tree where you're giving it's a chance of immediate death to get full health. Time trade-off is a similar concept, but you're actually giving up some of your life to obtain full health. A rating scale is very similar to the 100 millimeter pain scale, where the subject just marks where their quality occurs on that scale. And several patient-reported outcomes instruments are used for utilities. The value of a utility normally is ranges from 0 for death to 1 for full health. Some of these techniques allow for states worse than death, and that goes to a -1. Be very careful when you're comparing literature, because if one study uses a standard gamble and the other uses a time trade-off, the utilities will have different values. So you need to compare the techniques to each other, or at least consider that there are differences. So let's look at our patient case. So patient did not receive a transplant, so he or she must choose either dialysis at a center for 8 years and then death, or ambulatory dialysis for 12 years, which is considered to be life, and then death, and using the following utilities. So you're using dialysis at a center for 8 years, which is 0.56 times the 8 years, plus 4 years of death at 0, which is equal to 4.48. Or you're doing 12 years of ambulatory dialysis for life, which has a much lower utility. And this would be 0.4. This would be 4.8. You subtract 4.8 from 4.48 for the going to the center and dying sooner from the 4.8, and the answer is 0.32 QALYs gained. And this is over a very long time period, so you can imagine how small these numbers are for an acute illness such as nausea and vomiting from chemotherapy. So what we looked at here was we looked at the models, we looked at sensitivity analysis, we discussed discounting, returning the value to its present value, the differences between the full assessments, cost-benefit, cost-effectiveness, and cost-utility. We looked at the cost-effectiveness plane with the thresholds that we're willing to pay, and this is a surrogate for value. It's the minimum value that we give for the outcome that we're looking at there. We discussed incremental costs and presented qualities and utilities. Now we're at the final aspect of our program, which is patient-reported outcomes. And these can be utilized as outcomes in full economic analyses or can be used for patient care. They're questionnaires. We also call them instruments, surveys, tools, and multiple other names, but they're basically questionnaires. A true PRO must be reported by the patient. A proxy assessment, which is a caregiver or clinician reporting for the patient when they're, say, children or unable to answer for themselves, does result in different values than what the patient would report. And you need to consider that. It measures the full spectrum of health from very, very poor to nearly full health. And what happens here is we get some ceiling and floor effects. Ceiling effects are the difference between very good health and very, very good health. And that's very difficult for someone to make a determination on. And it's similar on the floor effects, where you have very, very poor health versus very poor health, and trying to determine the differences in that when you're trying to answer a questionnaire. Good instruments have mutually exclusive domains as much as possible. Domains are the basic units of health. There are 4 essential domains: physical, psychological, social, and role functioning. Occasionally these are separated, and general health. Some instruments add additional domains or only work with a single domain. This may be, for example, satisfaction with the HCAHPS. And going back to that value equation for patient outcomes, where it's the clinical outcome plus the quality of the outcome plus satisfaction. You cannot substitute the results for satisfaction as a measure of quality. That is a separate piece of the equation. What we've found is that when satisfaction increases, quality may not correlate with that. It may increase, it may decrease, or it may have no relationship at all. And pain is a domain as the humanistic outcome. Questionnaire structure is very important. What you're using is items or item stems. These are single questions or statements that are specific for a single domain. And then you have response options that follow the item. Your choices are usually in a rank order, in an ordinal technique, maybe in a Likert scale. Often these are validated to have equal distances between the choices. The domain or dimension is the area being measured, the behavior, the experience, and the function. And usually these are measured by a group of items, more than one question. with the new shorter forms of many of these instruments, you may be measuring the domain with one question, but often you're measuring a group of items. And once you measure these, you get a scale. And these are items representing a domain, and you get the scores from each of those items, and you combine them to produce a score. An index is where you take all of those scores from the domains and you add them together, aggregate them. A profile is a list of those different scales representing a number of scores. So you can look at the index and then you can look at the profile to see where the individuals or the groups fell. And this is very useful when trying to decide what you're going to emphasize when you're doing a study or an intervention, because you can see where the biggest change in the domains are. A battery is very similar to a clinical laboratory battery in that you use several instruments to obtain the comprehensive understanding. You have two types of PROs. You have general instruments and you have specific instruments. General instruments are broadly applicable to the population. They compare across diseases because you're just looking at health in general. They summarize a range of concepts so that you get a lot of domains that are being looked at. And they have the ability to detect unanticipated effects because you're not being very specific for a specific disease state. The disadvantages is that they usually don't respond to smaller changes. They may not be relevant to a specific population, such as your patients with diabetes, asthma, kidney disease. But many of the large commercial ones have been used in specific populations and validated for that. They're often lengthy, and the results may be difficult to interpret in that your aggregate score may be the same for two groups, but the particular domains, if they changed in the same magnitude, may be very different for different groups in your profile. So a basic final score may be difficult to interpret. Disease-specific instruments have, these are specific for diseases such as asthma, diabetes, depression. They have advantages because they're relevant for that specific population. They've decreased the domains to only those for the population. They're much more responsive to change so that you can often use them to monitor individual patients. The disadvantages is that you cannot compare across populations, and they're not designed to detect unanticipated effects. And because the populations are smaller, we have less research data available from these. Your PROs have to be reliable and valid. Reliability and validity is the same as when you're looking at any research design. Reliability is that you get the same result each time if no change has occurred. And you cannot interpret a number that is not a true value. So it's essential that they be reliable. Validity is the correct question was asked and the result is accurate and precise. And when you're looking at an instrument and it says, the producer says it's been validated, what type of validity was used? There are multiple types: face validity, content validity, which are the easiest to measure. Construct validity, which is similar to the surrogate outcomes, is such as IQ. You can't really measure that, but you need to have a way to have a surrogate to come up with a different value, and that's where these instruments come in, and they have to be validated to determine whether or not the actual construct is being measured. You have factorial validity, and you have known groups validity, and various others. These are in your workbook. The problem with PROs is that you can have some systematic bias. Some people agree with any item regardless of the question. This is why you have a couple of questions for each domain, and you can write them in a positive, as a positive question and a negative question. And if they answer at the same end of the scale for that similar question, you know that they're doing acquiescence. A socially desirable response, they may not want to report socially undesirable behavior or feelings, and this can be controlled by using a technique to administer the questionnaires that is easier for the people to report socially undesirable. This may be a computerized version or a mail-in version where they don't have to report directly to an individual. And if you give a questionnaire too often, eventually all of the answers will be toward the middle of the scales, but you want to be able to use it often enough to detect the relevant changes. So systematic bias can be controlled by having an adequate sample size, maybe stratified, and using statistical analyses to determine whether any of these have occurred. PROs are used for multiple things, but they are designed usually for only one of the purposes, and this may be discriminative, and you're discriminating between individuals or groups to describe health status, and these identify areas of need for you to emphasize your interventions. They may be evaluated, so that measures the magnitude of changes. So if you do have an intervention, you can determine how much change occurred. Or they may be predictive, that identifying who has or will develop a condition, such as the probability of having a myocardial infarction if your LDL is within certain groups, or with your activity levels are in a certain area. Your health is very poor or very good, whatever the domain is that you're measuring. So you need to open your workbooks to the appendices A1 and A2 and look at the current physical and mental health scores compared to the June scores and what happened during that. And I don't have that in the slides, so you are going to have to open your workbook. I'll give you a second to do that. So what happened? Were both physical and mental improved? Were both physical and mental decreased? Was physical improved and mental decreased? Or was physical decreased and mental increased? And what you see is, compared to June, the physical domain has improved, but the mental domain has decreased. And in June, the individual had surgery for their pain. So at that point, their physical health was down because of the surgery. But maybe their mental health was up because they felt that the pain was going to be improved. But what we see in another domain is their pain did not improve very much, and that may be why their mental has decreased. So in order to use an appropriate PRO, you need to make sure it's for the intended use, either for the three types of aspects, and whether or not you want to use a general or a specific. It needs to be have the validity and reliability tested. It needs to be appropriate for the study, the content for the study that you're doing. Does it measure all of the outcomes, all of the domains, or do you need some additional instruments? It needs to represent the patient's perspectives and have a reasonable respondent burden. This is very important. This is the time and effort that the individuals put into completing the instrument. It needs to be readily available. You really don't want to make your own because of all of those aspects. Is the method of administration appropriate? Is it only used via a landline, which as you know would not be a very effective measurement any longer? Or is it computer provided? Mail in, mail out. Do you have to pay for it? Most of these instruments you do have to pay for. If you have a very small budget, you need to look for instruments that are in the public domain. Do you need computer technology and the special databases to collect the data? And do you need additional personnel? The domains, and you may need more than one instrument to collect all of the domains. Systematic bias can occur, but you can do some controls for that. There are two general types, general and disease-specific. They need to be reliable and valid. You need to use it for the appropriate purpose, and importantly, you need to monitor for respondent burden. So as a conclusion, the basic knowledge of pharmacoeconomic evaluation and PROs is needed by clinical specialists in this world of value-based purchasing. You're using it for your decisions, and it's useful for interpretation of the literature. Conducting small studies at your institution could be a consideration for your MUEs, and opportunities to participate in larger studies. Any questions? If so, this is my contact information, and you're welcome to submit questions to me.